first. System-wide, we have performed 765,581 tests. The important point there, I think, is that that's over 20,000 additional tests since a week or two ago, which is one helpful thing. I think we're testing more than we were for a bit. System-wide, we have tested 912 people, 70,500 positives for an overall positivity rate of 15.8%. And at Baptist Memphis, we've tested 68,138 people, 7,100 positives for a total of about 10.1% in positivity. If we look at hospitalization now, we see at Baptist Memphis, there are 60 people in acute care non-ICU beds with COVID-19.
And become self-sufficient. Jennifer Aniston says for her, it was when she moved to.
Thanks. So there's 60 people in non-ICU beds with COVID, and
I've gone through phases of knowing for sure. I probably thought when.
Okay, sorry, thanks. So there's 60 in non-ICU beds with COVID, and there are 29 patients in the ICU with COVID-19 at Baptist Memphis. 16 of those 29 people in the ICU are on ventilators. If we look at Baptist DeSoto, there are 51 people in non-ICU critical care beds there with COVID-19 and 9 in the ICU. 8 of those 9 people at Baptist DeSoto in the ICU are on ventilators. So the number up to 89, nearly 90 at Baptist Memphis, and 60 at Baptist DeSoto. So continuing to climb at a very uncomfortable rate of admissions with COVID-19. And I would say too, it's what is further a little distressing is that there's been a lot of discussion about whether this variant is more virulent, more difficult and harder on people, more deadly than the Alpha and previous variants. There's still some controversy about that. We talked before about these original data from Scotland that suggested the two times the rate of hospitalizations per case. And I think we're seeing something that's interesting that we've mentioned before, but a larger percentage of the people admitted to the hospital are admitted to the ICU. There obviously could be several factors at play there, but I think I've mentioned before that at the peak of the pandemic, when we had 172 people in the hospital, we had a 52% rate of our ICUs being occupied by COVID patients. When we look now, the numbers are just are 80, and I think even last week we're up into the 34% of the ICU is taken up in beds occupied by COVID people. So you can see that if we extrapolate that to numbers from last time, it would be a much higher percentage of ICU beds occupied by COVID patients. So those are all rather disturbing, certainly concerning trends. So happy to answer any questions if anybody has any.
Hey, Dr. Threlkeld, it's Corinne. How are you?
Hey, Corinne. I'm fine. How are you doing?
Tired, but okay. Probably like yourself. So, you mentioned this acceleration in the number of COVID-19 patients who are being hospitalized at both hospitals. How close are you, or I guess maybe the better question, are we on trajectory to see the types of numbers hospitalized that we saw in January?
I'm almost hesitant to answer the question because at every juncture, we have underestimated this virus, I think, locally, nationally, internationally, and that's not a criticism. I have done it too. So we're clearly on that trajectory. There's no question about that. The slope of the line that we're on is fairly unnerving. So I think that it all comes down to who's susceptible to that. And it really is almost all the unvaccinated people out there. We have occasionally seen vaccinated people hospitalized. It is the vast exception. And typically it's someone who was immunosuppressed and couldn't get good immunity. There's one or two that we've mentioned that had really, really large inocula. That is to say they were around a face full of virus that they didn't realize they were getting into, which is its own small continued, I think, argument for masking in those circumstances where you're most likely to be in that kind of exposure setting. But sure, I think we're all very concerned. Now, the good news is that we've done it before, and I think we're unlikely to I think we're unlikely to truly achieve the numbers that we had before, just because so many people are in fact vaccinated. But again, the counter to that is that so many people in fact are still unvaccinated. And I, again, just left a unit. I've kind of been down these numbers before. The numbers will be similar because a lot of the people are still there. 2 people in their young to mid 20s, a couple of people in their 30s. We've lost a person in the 40s in the last week, and then one in the 50s, all unvaccinated, all on ventilators, all in danger. And so those numbers make us very concerned. And I think, yes, we're on the trajectory for it to be as bad as it was before. I still believe, as I did in the beginning of this onslaught of the Delta virus, that it will fall short of that, simply because we do in fact have a lot of people vaccinated, and we have a disproportionate amount of the most vulnerable, that is intrinsically the most vulnerable people vaccinated. The elderly are vaccinated at a very high percentage, thankfully, or this would be much more disastrous, honestly, than we're seeing. But again, we've done it before. We had the flexibility to handle the problem, but very honestly, you said you were tired, and I am too. I think healthcare workers, they're very tired, and they're very distressed, and they're discouraged. People really haven't gotten the vaccine, and we see all kind of arguments about it, and those are a separate conversation. But this doesn't have to happen. I mean, everybody in our ICU is unvaccinated, and so if we get the vaccine, this thing would go away in the form that we're experiencing it now. And some of the nurses, their hours in these rooms, never mind the potential risk to themselves of getting it. It's just very exhausting, particularly for them. And so it's a sad thing that we have to go through this again. But yeah, I think we're on that trajectory, although I'm still hopeful that we will fall short of the true numbers that we saw in the hospital before.
Hey, Dr. Threlkeld, this is Dominique.
Hi, Dominique.
Hey, could you just touch on what tripwires will have to be for elective surgery to be delayed or postponed?
Yeah. Well, I don't know what an exact tripwire is. I think we've certainly tripped over tripwires as a community and a country along the way. So it's not always helpful to put a magic number on something, because it fails to point out that there are 5 factors or more that might go into that sort of thing. I'll tell you this, though, all of those conversations are on the table, and that sort of thing is obviously being discussed even as we speak. I mean, people are tired. The hospital certainly is getting more full of COVID patients. And I think it just comes down to the ability to staff hospitals all around the country, here included, with people who are able to get the job done physically and have the numbers to do it. And sort of that really prompted it last time. Though we may not be there at this instant, we certainly are aware that the trend is in that direction. If there is a number, I don't know what it is. I've not heard any number thrown out there for this institution or any other one for that matter that says if we get over 110, we're going to curtail. In fact, you can do it in a graded fashion even, and I would anticipate that sort of thing would be the case. For example, one could say, okay, you might stop elective procedures that require a hospital bed and not ones that don't. I think we utilized that last time. For example, if you're going to go home after your surgery, it's not going to take up the resources of a hospital that a larger elective procedure that would require someone to be in the hospital for a couple of days. So I would anticipate if the numbers continue to go up, that's the kind of thing that we'll see initially. Obviously, we and others are prepared to do everything we did last time, including that. We thankfully have 22 hospitals that we can distribute or we can use to distribute personnel, items to take care of people, and that gives us a nice buffer zone and an advantage. But so I'm not aware of a specific tripwire that would require discontinuation of elective procedures, and I think it will be a little bit more nuanced than that. We'll see. If the numbers continue to go up, we would probably see in any number of healthcare institutions that you might limit some of those procedures. And we just hope that we don't get to the sort of situation that we're seeing in Missouri and Arkansas, where hospitals are underwater. That it's not a question of stopping elective procedures. They don't have anywhere to put anybody. Thankfully, Memphis is equipped with more beds per capita than almost anywhere in the country. At least that's the history of this place. thankfully, with several very large private hospitals here. So we hope we don't get into those kind of situations, but all those things are being discussed, and regular meetings, and I'm sure that's true of every healthcare institution around this town, to try to prepare for that. We were fortunate the first time around when this first hit us. We were able to watch what happened in New York City and a couple other places and realize this was not a minor issue, that this was going to be a potential catastrophe. And so we made plans. And those plans are still there, and they can be. It doesn't take long to dust those off and to utilize them again now.
Well, I'll jump back in with another question.
Sure.
You know, you mentioned this doesn't have to be happening, and you and your colleagues are tired. Talk a little bit about just the physical and mental toll that having to go through this again when we finally have the tools to maybe not end this pandemic, but really put it back in the box.
Yeah, that's probably well put. We can't end it, and there will be problems because we haven't ended it, and because worldwide we're nowhere close to ending it, and this generates a lot of thoughts and discussions. But you know, these variants are out there, and they're not slowing down. Places in the world, the majority of the world hasn't had anything like the vaccinations that we've had. So a new variant is a plane flight away from being inoculated into our city. But right now, we have the capacity, if not to eliminate the transmission of this virus, certainly to eliminate the severity of the worst cases. And yeah, I mean, look, my colleagues have left the hospital after 1 o'clock in the morning every night this week. And there are just a lot of people who are sick and in the hospital, and the critical care doctors and infectious disease doctors and the nurses and other people. I mean, just a whole crew of folks who are working a lot of hours to try to fix this. And it is disheartening to see some people that just are ignoring the facts of it. They still don't think this is that big a deal. And that's distressing and discouraging to those people who are working some almost beyond their physical limits to take care of people that have had that idea and were wrong. And you know, they all change, most do anyway, when they get sick and can't breathe. But it is a very difficult thing to do again. We have the solution to the main problem, that is hospitalization and death. We can turn this into a large nuisance, mind you, but we can turn it into something that does not lead to people in large scale being hospitalized and to dying from this. But we can't seem to give it away when we have it in our hand. And we can talk at any time about what those reasons and excuses are. And I spend a large portion of my day talking to people who don't want to get the vaccine, for example. But again, the numbers are just staggering now, and these numbers don't have to occur. You hear nationally people refer to it as a pandemic of the unvaccinated and unprotected, and the numbers really bear that out. We don't see anyone in the hospital essentially who has been protected by the vaccine. But the one other thing that we have to think about it, and this is probably a good time to mention that, I am increasingly sort of bewildered by the fact that this is very, very confusing, and the message is hard. I don't envy the CDC or others who are trying to put out messaging that can help people make sense of this and tell them what to do. That messaging has not been great or consistent throughout this pandemic. No one would argue that. But we've all seen this coming. There's nothing in the CDC change of thought and recommendations last week that we haven't talked about for a while. A good 2 weeks before the CDC made its changes to its recommendations that were roundly criticized by some people. I said in this venue a couple of weeks before that we have seen more breakthrough infections in the 2 weeks before I said it than we had seen in the entire cumulative months of the pandemic prior to that. It was no secret to those of us on the ground that there was some resistance by this new Delta variant to this vaccine. The problem is that we're all driving around in speedboats at the water level and can see these things, but really can't do a lot about messaging about it in any large scale thing. The difficulty is the CDC is in a much different situation. They have to take all that information from water level and collate it, study it, look at it, make sure the signal is a statistically significant thing. And then they have to change messaging, which I akin more to changing the direction of a tanker on the ocean rather than the smaller boats that those of us taking care of people are driving. And that's a much harder and larger thing to do. But the message is this, and if I could state it succinctly, and I think we've had a hard time doing that nationally, the message is this: this virus is a tremendous danger to people who are unvaccinated. It is probably more dangerous than ones before. It's a little controversial still, but I think, as we mentioned before, more people are making it to the ICU in their 20s, 30s, 40s, 50s. So it is not something to fail to be concerned by. But the vaccine is great at protecting everybody from hospitalization and death. At the same time, it's not as good anymore at keeping you from getting infected at all. And the importance of that, very simply, is that you can get it almost as easily as you could without a vaccine, but you can't really get sick from it. But you can give it to other people very easily. So really, the vaccine is serving to protect you from illness, but it is no longer as good at protecting other people from you if you're exposed to the virus and have even a minimally or asymptomatic case. So we see these things, and that's a very difficult message. We're swimming between rocks that are very difficult to get through when you're messaging that to patients. I've seen a couple of people who were very smart people, very good folks that I was taking care of in the hospital this week, who sort of were frustrated, and they said, I haven't gotten the vaccine yet. And I said, why? And they said, well, it's just the whole thing is very inconsistent. What do you mean inconsistent? Well, people, they're getting the vaccine, but they're still getting the infection. And so this is a concept that we have to just, I think, continue to beat the drum. Get the vaccine because it keeps you from dying. And that, after all, is still job one for a vaccine. But still be careful after you get the vaccine, because the virus is moving away from us in its mutations. It's moving away from our immunity, both past infection and from the vaccine. Not far enough to make us sick if you've been vaccinated, but enough to allow you to get a minimally symptomatic infection and giving it to somebody else, maybe a loved one who is less immune, who is older, who may be immunosuppressed and didn't get a good response to the vaccine, or someone who didn't get vaccinated at all. We can still be a danger to those people in a larger sense than what we could before this. So that message is a hard one to get across to people, but it is absolutely crucial. I mean, I've seen physicians, somebody sent me a picture today of a sign in a physician's office that said, don't need to wear a mask in the inside the office in the exam rooms because Dr. So-and-so and nurse so-and-so are fully immune. There's no one who's fully immune anymore from the infection itself, and therefore giving it to someone else. You may be immune from getting really sick from it, but these concepts are failing some degree even with physicians, let alone people who are not trained in science. But it's a message that we need to, and I apologize for being redundant, but it's a message that we need to continue to stress, because it is the difference in putting this back in the box, as you said, or letting it smolder on for a long period of time when the next variant will come downstream. And who knows, when the Omega variant hits us, that is more still resistant to our vaccine and to natural immunity, that we're back to square one. We have to make new vaccines at that point. And that's not being a scare tactic. That's just the direction that we are on. And all of us have underestimated this virus, as I mentioned. But when we started this, we said, okay, we don't really see much in the way of variation. We're not too worried about it. It has a proofreading mechanism in this virus that keeps it from mutating very quickly. It mutates much less fast than the flu, for example. All true, all very true. But it's happened. And then we had the Alpha variant, which is the first variant that made us say, oh gosh, this is a lot more contagious variant. We have a problem here. And so it caused spikes after that. But then the vaccine came along and we got very happy, as we should have. And we said, gosh, we have to get the vaccine in before the Alpha variant hits us. Well, we didn't. And so the Alpha variant made it all over the place. And then now we're saying, okay, well, we have the vaccine now. And now comes the Delta and the Gamma and the Beta and the Delta Plus and the Lambda, and all these variants are going to be more resistant to our immunity, both from the actual natural infection and from the vaccine. It is, the virus up to now has been replacing other versions of it. See, they're competing with each other, these viruses are. Not just trying to kill us, they are competing with each other. and replacing each other. And it used to be that the faster virus and more efficient virus was the one that replaced the others. Now, it may become the point where there'll be enough people who've had the infection and even vaccinated. So the pressure on these variants in fighting each other will be which one does a better job of evading our immune system. The greased pig analogy, if you will. So the slipperier piglet is going to be the one that our immune system can't catch and put away. And so those could be the ones that start replacing just the more contagious ones. So these are all just things to be concerned about downstream. But again, sorry to eventually circle back to your answer. Yeah, people are tired of this. They can see that there are more dangers downstream if we don't do what we need to do to put it back in the box. And I think that's what we have to do.
And one more question. I promise this will be my last one, at least for today.
It'll be my last 10-minute answer, so we'll be even. So
perfect. So can you talk a little bit about the Lambda variant? We're starting to hear about it, but I personally just don't really know a lot about it.
Well, you're in good company because we have to learn a whole lot more about that variant. The Lambda variant and kind of the Delta plus variants are kind of the ones that are the variants of interest out there that we're trying to learn more about. People talk about the variants of interest and the variants of concern. And when you look at the variants of concern is obviously one step above the variants of interest. And the variants of concern are limited to the alpha, the beta, the gamma, and the delta now. But there's the Delta plus, for example, and it's been in several countries, the UK and a few here as well. It's not clear yet as to how well it competes with the original Delta variant. It's got an additional mutation in there that makes it a little bit more like the Alpha and or the South African variant, that it might be a little more resistant to our antibodies. The Delta similarly began in Peru right at a year ago, and it is also a variant that it's spread more across South America, but a little bit into the southern United States as well. I think there are fewer than 1,000 cases that have been identified by sequencing so far of Lambda in the United States, but we don't sequence a lot compared to what some people have done historically. So there may be a lot more of it here. It, like the variants that we're looking at now in Delta, is probably more contagious, maybe significantly more contagious. The mutations in the spike protein in Lambda not only seem to make it more contagious, like Delta, but it may do a better job of being resistant to the antibodies that we have made, maybe to natural infection, maybe even to the vaccine, though all the data that we've seen so far would suggest that the vaccine still does protect adequately against the Lambda variant, but it's earlier, it's early on. So the real concern is that these variants are increasing in their ability to avoid our antibody protection and our immunity. That's what we're trying to stay away from. And the more these variants, I mean, if you look at the mutations in these viruses, I think something like 1 of every 10 replication cycle, every time the virus copies itself, 1 in 10 copy attempts, it'll have a mutation. And because of all the ways that it tends to sort of avoid some of those, it has mechanisms to prevent the mutations. So you say, well, that's not very often. 1 in 10 copy events causes a mutation or a variant. Well, that may not seem like a lot, but when you start looking at the fact that there may be 10 billion virus particles in a given person who is infected, then all of a sudden you can see that there may be 1 billion different variants in a given person per day. So across the world, there's a huge variation in these viruses. Now, thankfully, most of those mutations do not cause them to be any more dangerous to us. In fact, mutations tend to make the virus less productive and they just go away. But every now and then something happens that makes it more efficient. And that could be it makes it more contagious, as we've talked about. It could even be that it makes it more deadly, as we may or may not be seeing, possibly seeing a little of even in the Delta variant. But those viruses have to compete with each other. And so it's not just important what these viruses do to us. It's also important as to how they compete with one another in getting to us and surviving our immune system, if you will, and getting on to the next person. That's how they compete with each other. So limiting limiting our ability to knock them out with our antibodies is going to be maybe the next phase at these viruses competing with one another. And the fact that they're more contagious and hitting us with larger numbers, as is Lambda as well, It means that they get a more rapid start out of the blocks in the race. I mean, all infections are a race between a virus or whatever the infecting organism is and our immune system. The immune system doesn't start until it sees the virus inside of us. It finds something that's foreign, in this case, the virus, and then it jumps to action. So the virus always gets a head start. But these really contagious ones that are very efficient get a faster jump out of the blocks. The difference is that the people who are vaccinated and have pre-existing immune function that can block it off have a wall of protection between the starting blocks and the finish line. And people who are not vaccinated don't have that. And it's why you're seeing those people who get much more serious illness and death, whereas the people who are vaccinated, we have mechanisms to slow down that virus very quickly once it jumps into gear and gets going, because it jumps into gear a lot faster if it's seen it before. So those variants are potentially important. They're still listed as variants of interest, not yet variants of concern by the CDC. But there are a lot more variants. There's the Eta variant, the Iota variant. The variants are going to be out there in large numbers, but that's why there's an attempt, obviously, to watch them closely to try to find out what the next Delta might be and what we can do to prevent that.
Could you talk a little bit about, it's floating around the internet again, people using active immunity because they've had COVID as their excuse for not getting a vaccine?
Sure. And so the term active immunity to an immunologist simply means immunity that you have had when the immune system has seen something and responds to it specifically, so that it has memory troops who are patrolling around from then on for the rest of your life, who are ready should the perpetrator who matches the description of the first guy come back into the neighborhood, you're ready to pounce. And that's all active immunity is. It's what our immune systems do, and they do it very well. Passive immunity is when you get actual immunity transferred to you from something or someone else. Someone would be an example like a newborn gets antibodies, IgG antibodies, that cross the placenta from its mother. And so the newborn is kind of relatively well protected for some weeks after delivery compared to, say, 6 months old, because they're getting part of mom's immune system put right into them, injected in at the time of birth. After that, they're on their own. Once those antibodies wear off, they have to make their own immunologic reactions. Another example of passive immunity would be our giving both convalescent plasma from a person who had made their own immunity. We take their antibodies and inject them into us. Another one that we're seeing a lot now, of course, is the monoclonal antibody injection. Those were just taking an immune product and injecting us directly into someone. We don't have to do anything. We are the recipient of some other immunity put into us. It's passive and it doesn't last. It only lasts as long as those antibodies, for example, survive in the bloodstream. That could be a month, out to a little bit longer sometimes, but that's what passive immunity is. What the general fallacy is, and the idea that active immunity is natural infection. Natural infection and vaccination-induced immunity are both active immunity. The immune system sees something, it recognizes that it's not us, it's foreign, and so it takes off and makes that reaction so that it will be ready next time. That happens in somebody who takes a tetanus vaccine, and it happens in someone who gets tetanus. We greatly prefer the former. It's a lot more user-friendly. So the vaccine will cause active immunity just like a natural infection that the vaccine is mimicking. Vaccine, as I say, is greatly the better option. So it's not the case that natural infection and natural immunity is superior to a vaccine-induced active immunity. We saw this, I've mentioned the Manaus, Brazil example. It's true of a lot of other places. These variants are what ensure that. Variants will change from that natural immunity and they can reinfect you. They can even kill you again, as we saw so much in that South American outbreak. So there are pretty good data that even in people who have the past infection, and that immunity may last quite some time for people who have been infected. The problem is that it's lasting against something that no longer exists. You don't have the Wuhan variant or even the Alpha variant anymore. So your immunity to that is going away, not because the antibodies are waning, not because immunity doesn't last a long time, but like the flu, next year's flu is not going to be as worried about your last year's antibody to last year's flu. And it turns out that the vaccines seem to do better at that so far. If you look at test tube examples, these are hard data to generate big clinical trials on, but all the data would indicate that you're better off with the vaccine than you are with yesterday's or last year's natural immunity. And just as one last kind of thing to mention on that, there's some discussion about that when you talk about a third vaccine. People talk about booster vaccines. So I would use the booster term, to me, kind of is more using a third shot that is the same as the first two, as opposed to a new variant vaccine that Pfizer and others are working on to really take into account those mutations, the Delta variant, et cetera. But a booster shot will probably increase your numbers of antibodies if you take it. The problem is a lot of people, and I think I sort of agree with this posture, is that the virus is moving away from us by mutations and the like a lot more than we are moving away from the virus. That meaning that our antibodies are going away and there's just not as much of our protection anymore. I think most data still suggest that we have plenty of protection from months and even a year ago so far, but we're protecting against something that's not there anymore. And so if the immunity were really waning and we really needed a third shot or a booster shot in people who have normal immune systems, I think we would see things different. We would see more people who got the shot at the beginning of the time getting sick and getting into the ICU because their immunity was in fact waning away. It's not what we're seeing. We're seeing people who got the vaccine even early on being very well protected against severe disease, and the people who had the vaccine or the natural infection from 2 months ago still potentially having the same degree of ability to get an infection, but they're protected against more serious disease. So it really makes more sense to me that at least as things stand now, and we're all open to whatever data come down the pike, but I would anticipate that we'll need a vaccine against a variant or the accumulation of those variants before we would necessarily need a booster vaccine against what we already have. It's the old example that somebody once wrote, you'd be climbing a ladder faster, but the ladder is leaning against the wrong wall. And so it's not doing much for you just to boost antibody levels against something that's no longer there. And we've seen some of that too, very early stuff, and it's probably too early to even mention, but I will. Some people have said that, yep, that the antibody levels go up when you do a third shot, but they may not be neutralizing antibodies. They may not be those antibodies that do the most important job of putting the virus out of business. So there's a lot more to come on that that we can see. But immunity is an incredibly intricate thing, and it can be hard to lay down large trials to demonstrate this. But I think that's what you may see. Now, all of what I just said does not count with immunosuppressed people. Our solid organ transplant patients, heart transplants, kidney transplants, that's different, and they may benefit from a third booster to really try to jack up the levels of the antibodies that they didn't get enough of the first time. That's an entirely different thing. Any other questions? Okay, be safe. Thanks.